Okay, I think we will go ahead and get started. Good afternoon, everybody. Thank you so much for joining us for this lung cancer and low-dose CT webinar hosted by Appalachian Regional Healthcare. My name is Danielle Harmon, and I will be your moderator for today's webinar. Today, we're going to hear from two professionals in low-dose and lung care, our low-dose screening program navigator, Rochelle Waddell, and our own Dr. Hal Sreden. Before we get started, let me tell you a little bit about Appalachian Regional Healthcare. ARH is a nonprofit healthcare system operating 11 hospitals in southeastern Kentucky and 2 in West Virginia. We are the largest provider of care and the single largest employer in southeastern, Lord, I'll get that out, Kentucky, and the third largest private employer in southern West Virginia. We operate multi-specialty physician practices, home health services, home medical supply stores, physical, occupational, and speech therapy, and retail pharmacies. Our mission is to improve the health and wellness of Appalachians, and that's why we do educational programs and webinars like this one to help us fulfill that mission. Some housekeeping items just before we get started. I say this in all of our webinars, but the Q&A session or section will be open throughout the whole webinar, so please feel free to use that or the chat and participate, ask questions however you would like to. Our experts cannot provide specific medical advice or referrals on this webinar. We have to say that. So if you do have any medical questions or need a referral, please consult your healthcare provider, or if you need one, we have plenty on arh.org that will be able to help you. So with that, our first speaker today is Ms. Rochelle Waddell. As I mentioned before, she is our low-dose and lung cancer screening program navigator. Rochelle, I will hand it over to you now, if you don't mind.
Thank you, Danielle, and thank everyone for taking your time out this afternoon. My name is Rochelle Waddell. I'm the service line coordinator for lung cancer screening here with Appalachian Regional Healthcare for the whole system. I focus mainly on lung cancer screening and low-dose lung CT. So we'll jump right into it with smoking. Smoking is the reason that we try to do lung cancer screenings, and to get started with, cigarette smoking remains the leading cause of preventable deaths in the United States, despite a significant decline in the number of people who smoke. Cigarette smoking has an adverse impact on health as the leading cause of preventable death and disease in the United States, and is responsible for more than 480,000 deaths every year. Smokers live an average of 10 years less than non-smokers. Over 16 million Americans have at least one disease caused by smoking, and that may include heart disease, stroke, respiratory diseases such as COPD, diabetes, and multiple types of cancer. The highest rate of deaths attributed to smoking occur in the southern states of Kentucky and West Virginia. Kentucky consistently ranks number one nationally in smoking with lung cancer and deaths from lung cancer, and ranks number two with lung cancer screenings nationally. So 24.4% of Kentucky adults smoke, with 70% of smokers want to quit smoking. Now, this is just a picture of healthy lungs compared to lungs that with someone that smokes and with may show fatal lung cancer. So our next category is going to be talking about lung cancer itself. Kentucky ranks worse with number 50 in the U.S. for cancer-related deaths. Lung cancer causes about 160,000 U.S. deaths a year, which is greater than a combined total of colon, breast, and prostate cancer. Incidence in the number of new lung cancer cases diagnosed each year in Kentucky is around 96.8%, which is much higher than the national rate of 63 and ranks 51st among all states. Lung cancer is the second most common cancer in both men and women. Lung cancer accounts for most cancer deaths among men, which is 26%, and women, 25%. So here with this slide, you can see the difference between an X-ray compared to a CT scan. So lung cancer screening is looking for cancer before a person has any symptoms. This can help find cancer in an early stage. When abnormal tissue or cancer is found early, it may be easier to treat. By the time symptoms appear, cancer may have begun to spread. With the low-dose lung CT and screenings, the low-dose lung CT scan has been shown to decrease the risk of dying from lung cancer in heavy smokers. And as I said before, there is an example with a chest CT compared to a chest X-ray, and whereas a chest X-ray will not pick up the nodules like a chest CT will. A little more about the low-dose lung CT scan. It's a CT scan that provides an image of the inside of a patient's body with minimal radiation. This reduces the risk for patients by limiting overall radiation exposure in association with the medical imaging study. A low-dose CT scan is non-invasive medical image test that is used for early detection of lung cancer. Lung cancer is detected at an early stage. It's more likely to be cured with treatment. The CT lung cancer screening, the low-dose lung CT scan, is an annual screening, and it's non-invasive. It's a painless procedure that uses low-dose X-rays to screen the lungs for cancer in just 30 seconds. A CT lung screening allows the radiologist to look at different levels or slices of the lungs using a rotating X-ray beam. It is performed on a multi-slice spiral CT scanner and can detect smaller nodules or cancer than standard chest X-rays. So the eligibility for lung cancer screening comes from our Center for Medicare and Medicaid Services, which is CMS, and that is what we go by. The patient must be 50 to 77 years old, asymptomatic, which means no signs and symptoms of lung cancer, such as new shortness of breath, coughing up blood, fever, chest pain, or unexplained weight loss, has a tobacco smoking history of at least 20 pack years. That is a little confusing at times to decide how that would calculate, but it's 1 pack year equals the smoking 1 pack per day for 1 year. So it's a pack, every how many packs a day you smoke, times the number of years that you've smoked. And it must be a current smoker or one who has quit smoking within the last 15 years. And you must receive a written order for lung cancer screening for the low-dose lung CT scan. Written orders for lung cancer screenings must be appropriately documented in the medical record. So a doctor must write that order. Now, within our ARH, lung cancer screenings and low-dose lung CT scans are available at all ARH, all 14 locations.
Thank you. Oh, sorry.
That's fine. And just some contact information if anybody needs any more information or would like to discuss a lung cancer screening low-dose CT, they will be able to reach me through the website. It's arhlowdosect.com or arh.org will also take you to it. The phone number and my name, email address, any way that anybody wants to reach me, please feel free to give us a call.
Thank you, Rochelle. And we also have on that website the risk assessment as well. So people can take just a little short quiz to find out if they would qualify for a low-dose CT. Is that correct?
Yes.
Okay, perfect. So I know you're switching places there. I want to introduce Dr. Hal Sreden, who is a proud member of our pulmonology team, which provides comprehensive care for patients that have respiratory issues. So thank you so much for being with us, Dr. Sreden. I will hand the reins over to you.
Great. Thank you very much, and I appreciate everybody showing up today. I just thought it was important to highlight a few things, a couple of slides, and certainly any questions you have. I think it's also important to highlight that even if you don't meet screening criteria, let's say you have new symptoms, maybe suspicious for lung cancer, the screening really applies to people without new symptoms. But if you have a new problem, that doesn't mean you can't have an evaluation. It just goes through a different route, a different type of CT scan, and usually a pulmonary consult. So just sort of keep that in mind. We're trying at multiple levels and different avenues to try to reduce the cancer death rate, and getting in the system will help us navigate your course through this. Sometimes there's a little bit of confusion about how we interpret CT scans, and I just wanted to highlight that. Every scan is reviewed by a radiologist, and then scans that are more concerning for possible lung cancer are then reviewed at a panel, which is a centralized panel that covers all of ARH. So every scan is assigned a category, and in this table, you see there are categories 0, 1, 2, 3, 4A, 4B, and 4X. And that's based on the findings that you see on the left, the appearance of the scan, any nodules or spots on the scan, what those look like, their size, whether this is a new finding or a finding that's been noted before, and in particular, if there's any change between scans. So the first scan is very helpful, but the power of surveillance over time is really what this program is about. And as you see highlighted in the bottom of this table, that we're most concerned about categories 4A, B, and X, because the probability of cancer is much higher, and that leads to enhanced monitoring. So patients in category 1 and 2 will just routinely have an annual scan, which is the baseline surveillance is a once a year scan. Patients in category 3 will have a scan at a shorter interval, typically at 6 months. And then patients in categories 4 will have a review at our panel and then a decision as to what the best course moving forward might be. We try to do additional non-invasive evaluation like a PET scan, but sometimes we do need to move forward with biopsy or surgery. And that's all managed at the central system level, with the care itself being delivered locally. Just go to the next slide. The reason why we're really interested in those category 4 patients is highlighted here. It's generally based on the change over time. Sometimes the initial scan is concerning, but more often we're picking up changes over time. We know that 95% of all scans will not show a cancer. So coming in, it's very unlikely that a single scan will show evidence suspicious for cancer, and 85% are in those low risk groups, categories 1 and 2. Categories 4A, B, and X make up probably about 6% of all studies, and only about a third of that small slice of the pie will actually ultimately be shown to have cancer. And as I said before, really the power of this program is monitoring patients over time. So we want to get your first scan done, but just as importantly, we want to have that follow-up scan and not have you drop out of this program. And that's really a lot of what we do is making sure that we navigate the patient through the program. Rochelle's done a great job with that, and we're always available to answer any questions you might have. So at this point, I've just opened it up. If anyone has any questions, please feel free to ask them.
It's muted. I don't see any in the Q&A or the chat, but I will ask for you, Rochelle, I guess, to explain a little bit about the program. What happens when you get a referral from a patient, and kind of walk them through what that program looks like over a year, over 2 years, and how they kind of stay with you and follow up.
Okay, would love to. Once the patient goes to the provider's office and has been deemed that they qualify for lung cancer screening with the criteria that I had said previously, the patient would then just get a quick assessment from the provider, get the order for the low-dose lung CT. From there, the office and my office will take care of getting the patient scheduled. We will give them a call, get them scheduled at a date that's convenient for them, and a time and a place at one of our facilities closest to them. We will take care of getting their insurance to make sure. And with insurance, the lung cancer screening, as long as the patient meets the criteria, it should be at no cost to them. And we will take care of that, reach out to the patient to let them know that also. Once the patient then goes and has the exam, the results come back to us also. We make the provider aware to follow up with that patient. And just most recently, we will start sending out letters to patients to let them know the results also. That in the next little bit, that is something new for us, getting ready to come up. And with the provider, they will reach out to the patient, let them know what the results are, and let them know when they need to follow up. And as Dr. Sreden had shown a list of how the categories go, if it's a lung grad 1 or 2, the patient is an annual screening, which means you should be good to go for another year. Then if something comes back and they are wanting to monitor or needs a further follow-up, then those patients will get a notice from us and from their providers to do that follow-up, whether it be 6 months or 3 months or what they might need. If it is a sooner need to be followed up with immediately, they will be contacted by the provider's office and by this office to get that follow-up. They are also, during that time, it's another, if it's deemed to be a category 4, the 4A, 4B, 4X, then those patients are also reviewed in a lung nodule review board and also get recommendations from that. And so the provider, there's a chance that that patient could be looked at a couple of different times to make sure we're getting the best patient care that we can for those at risk. I'm not sure, have I answered all of your questions?
Yeah,
Okay.
absolutely. So I think that one of the biggest takeaways is that you're totally navigated. It's not like you get a screening and then you don't know, what happened from it, or you have to call and try to find out from your doctor's office repeatedly. You are fully navigated, and then not just for that time, but once you're in the program you are in and will be followed up with, and you have somebody that's going to call you and make sure that you're, getting those screenings annually.
Absolutely. And Danielle, also, I want to mention to the folks that are on the call and anybody that is listening to the presentation, to make sure that they're signing up for the patient portal, because those also show your appointments, your results, and any other related information that may be needed as far as appointments. If we make an appointment for you, it also goes on that patient portal. You'll be able to see that. So any patients can also sign up for that for means of contact. Because the quicker we can get a patient in and get those patients followed up on, the better for the patient.
Sure. Dr. Sreden, can you talk about some of the successes that you've seen from this program?
Yeah, I think ultimately this program is really centered on finding the patient who potentially could be cured of cancer. And we've had patients that have come in with nodules or spots on their lungs detected only by CT. You would never see them on a plain film. That ultimately turned out to be early stage cancers that were cured with surgery. And that's really the ultimate goal. Unfortunately, many patients will not be in that category. Either they can't be treated surgically because of underlying lung or heart problems. But yet, I think there's a lot of value in finding those patients. And I think the field in general has expanded to non-surgical options, which can potentially be curative, but at the very least can control cancer locally, extend life, and extend the quality of life. So we have more than one goal in mind. We'd ideally like to be able to cure, but at the very least, diagnose at an earlier stage with better outcomes overall. And the other thing I'd just like to point out is on my last slide, I demonstrated that the vast majority of patients don't have cancer. And I think it's really reassuring for patients who may be worried, particularly because of their smoking history. And we can reassure them with a scan, not that it's a lifelong guarantee, but it puts them in a program of surveillance where we can reassure them that if they do develop cancer, we're going to find it early and we're going to begin treatment early.
Mm-hmm.
So I think it's a great opportunity. It is covered by insurance, and as Rochelle described, it brings a huge amount of care to the person in a coordinated way. So you're not running from doctor to doctor and getting multiple procedures without a coordinated plan. So we really look forward to working with all of you. Hopefully, people on the call will be willing to participate and tell their friends and family about it as well.
Absolutely. I think that's one of the biggest things that needs to happen is just the public knowledge that this program exists and that low-dose CT exists, because it's a relatively new, last 5 years, I guess, newish screening, right? So a lot of people with lung cancer especially wait until they're symptomatic to go get things checked out. And at that point, it's in the later stage of cancer usually, correct?
Yes.
Mm-hmm. Yeah. So big takeaway, make sure that, if you qualify, that you become screened regularly instead of waiting, and early detection is most certainly key to survival. So anything else? I don't think we have anything in Q&A, nothing in chat. So with that, I will let you guys go back to your day and serving our patients. So thank you so much, Rochelle. Thank you so much, Dr. Sreden, and everyone on the call. Thank you again for being part of this program. We're trying to grow our low-dose CT program, but also just to let people know about what low-dose CT is and everything that we do in our organization just to try to combat lung cancer. So thank you for being here. Please spread the word.
Thank you.